I'm Dr. Dean's colleague, come from the same hospital, and thanks give me the opportunity to give the topic about left posterior fascicular VT and post-tendon, the new insight of the tachycardia EP mapping and ablation strategy. We know that the LPF VT is the most common type of idiopathic VT come from left ventricle, especially young Asians. So most of people come from like Japan, China, and South Korea. This type of VT have the typical cardiac morphology, the right bundle branch block and left axis deviation. And most of the LPF VT is verapamil sensitive. So it also called the verapamil sensitivity. And I think most of the EP physicians so far still believe the VT originated from the Purkinje system. So that's the reason called the VT, the fascicular VT. We know that 25 years ago, Professor Nogami from Japan published this very important article in JACC. And they use a octopolar electrode catheter with 8 equally spaced electrodes positioned under the left ventricular septum. And during tachycardia, they can record a very clear diastolic potential with a sequence from the proximal to distal and pre-systolic potential just ahead of the local V potential. And the distal part of P1 connected with the earliest P2. So we tell P1 activate the P2. And about 30% of patients in their group, there were no clear P1 could be recorded. At the beginning, in the same paper, Professor Nogami draw the diagram, try to explain the reentry circuit. They show the P1 is the slow conduct zone as the antegrade limb of the reentry loop, and the P2 is the retrograde limb of the reentry loop. The distal part of the P1 connected with the earliest P2, and from this region activate the exit to the ventricle. As we know, this is the circuit just in the Purkinje system, and the ventricle is the bystander. Now we know it's not right. So about 10 years ago, Professor Nogami published the review in PACE, changed the diagram. The P1 is still the slow conduct zone and the antegrade limb of the circuit. And the P2, just from the connection of the P1, P2, the proximal part of the P2 is bystander. And the ventricle from the left ventricular septum is the retrograde limb of the circuit. This is our previous work. We use the duodecapolar electrode positioned at the left posterior ventricular septum. During tachycardia, a clear P1 potential could be recorded from the duodecapolar electrode in close to 70% of the patient. And in the other 30% of patients, it's difficult to record a clear P1 potential, but earliest P2 potential could be recorded from the duodecapolar electrode. And we use 2 pacing maneuver to try to explain the circuit of the tachycardia. The first one is R2 pacing. We introduced the PVC from the right basal septum. The PVC could not capture the immediate P1 and P2, just capture the immediate V potential, and then advance the next P1 and the tachycardia reset. This phenomenon proves the ventricle is part of the circuit and the P1 is very important. We can advance the next P1 and then the tachycardia reset. The other maneuver is progressive fusion, phenomenon progressive fusion. We use burst pacing slightly shorter than the tachycardial cycle length. We can see during treatment with different pacing cycle lengths, the trust morphology is different. This is called progressive fusion. That is a strong evidence to prove the tachycardia is a ventricular myocardium involved microentry circuit. So based on our previous study, we draw the three different type of diagram of LPL-VT. The only difference is the length of the P1. Sometimes the P1 is very long, parallel with the left posterior fascicle, and sometimes it's very short, so it's difficult to record using the dodeca polar electrode. And the microentry loop involves the ventricular myocardium. That is very important. And the critical circuit of the tachycardia is the P1 fiber. The slow conduction zone different with the Nogami's idea. We think the slow conduction zone not in the P1 fiber, not the P1 potential, not the slow conduction zone. The slow conduction zone just located under the proximal part of the P1 connected with the ventricle. This is the unique case in our group. We leave the dodeca polar electrode catheter and the left posterior left ventricular septum, and using the transeptal approach to put the ablation catheter just focused on the distal part of the P1 potential. When the during ablation, when the P1 block, the tachycardia terminated. The endpoint is the non-inducibility of tachycardia, and more important, when you can record P1 potential during tachycardia before ablation, when you just ablate the distal part of the P1, post-ablation, you should record a delayed P1 potential in this group. And we also can find that during burst pacing post-ablation, the SP1 is prolongation without the velocity change of the P1 potential. So we think the P1 is not the slow conduction zone. The slow conduction zone just located under the proximal part of the P1 connected with the ventricular myocardium. Now we know P1 is a critical potential in the reentry circuit, but what is P1? The anatomical substrate, we don't know so far. And we calculate and we measure the P1 and P2 velocity in our three published study. And we can see the P1 velocity is very slow, similar as the ventricular myocardium conduction velocity. And the P2 is similar as the Purkinje fiber. Previous some case report shown TTE or TE could observe some force tendon during his study, and using the mapping catheter could record some diastolic potential from the recorded force tendon, and just the force on the force tendon, ablate the force tendon could cure the tachycardia. This is the unique case report before the catheter ablation technology development. This sick patient with LPL-VT and TTE show a long force tendon along the located under the left ventricular septum, and surgical resection of the force tendon successful cured the tachycardia. And the histopathologic examination, we can see the force tendon involve some ventricular myocardium and Purkinje fiber and artery. So based on previous work and this some case report, we suspected maybe P1 originated from the force tendon from the myocardium on the force tendon. So we developed a desire this study, we're using eyes imaging during our EP study and ablation strategy for LPF-VT, and we can classify the 3 different type of force tendon. Type 1 is from the left ventricular septum to connect with the middle part of posteromedial patellar muscle, and the type 2 connects the left ventricular septum and the apical part of the left ventricular septum. The type 3 is rare. They connect the septum and the free wall. The most common type of the force tendon is type 2 in our study group. And this is the example show type 2 force tendon located under the left ventricular septum. We put the duodecal catheter guided by S imaging and 3D mapping system during tachycardia. We can record P1, clear P1 and P2 potential. And then we know the P1 come from the force tendon, this force tendon, and just focus on the force tendon ablate, and the tachycardia terminated and successful ablate the tachycardia. Post ablation, we put the duodecal catheter still under on the force tendon and record delay the P1 potential. And we also can find on the distal part of the P1 and the same level, the LPF, left posterior fascicle, also blocked. So this phenomenon just explain why previous strategy just ablate the LPF could kill the tachycardia. It's due to when you ablate the left posterior fascicle, you could ablate the block the P1 potential. This tracing is very important. Let us know why the P1 comes from the force tendon. This is the same patient with the type 2 force tendon. We put the duodecal catheter under the force tendon, and S1 S2 pacing from the right side induced tachycardia. During S1 pacing, we can see the proximal to distal part conduction sequence of the left ventricle activation, and from the distal to proximal activation sequence, this is the patellar muscle potential. And following the patellar muscle potential is P1, is represent the force tendon conduction. And after just following the S2 pacing, the P1 from the distal to proximal, it's going to reserve to the from proximal to distal activation sequence and connect with the P2 and the tachycardia induced. So from this tracing, we know the P1 represents the ventricular myocardium on the force tendon. So we draw the schematic representation. The tachycardia, the mechanism of tachycardia, it involves the force tendon myocardium and the local septal ventricle. This is the circuit just in the ventricle, involve the 2 different parts of the ventricular myocardium, and the left fascicle is bystander. Sometimes there are, in some patients, there are maybe more than one force tendon. So it's very important to know which one is the culprit. We need to know in this patient with the type 2 and the type 1 different force tendon, and then we put the duodecal polyarticular catheter and the 2 different force tendon. The type 2 force tendon could record the P1 potential. So we know so we know the type 2 is the culprit force tendon, and could then we put the ablation catheter just on the force tendon, type 2 force tendon, and we could also record the P1 potential from the ablation catheter. So this is the result. Most of the patients could record P1 potential from force tendon, and we just focus on the culprit force tendon could kill the tachycardia simply. This is the 4 steps based on our study. Just make the geometry and induce, and focus on the culprit force tendon and ablate at point. Thank you very much.